Welcome. I'm Lee Doherty Biddison.
And I'm Carolyn Kamsti-Fowler, and we're your co-hosts for the Johns Hopkins Office of Wellbeing's podcast, Vital Conversations, Influencing Workplace Wellbeing in Healthcare.
We spend a lot of time thinking about how to influence workplace well-being in healthcare, and we're excited to share what we're learning.
Thank you for joining us.
I'm Lee Biddison, Chief Wellness Officer for Johns Hopkins Medicine, and your host for today's episode of the Vital Conversations podcast. Today, I am joined by two colleagues from Johns Hopkins Medicine, Michelle Campbell, who is the Strategic Learning Center Senior Director and has over 20 years of experience leading ambulatory operations, focusing the last 2 years on development and dissemination of enterprise-wide training programs to improve EHR efficiency and operational performance. Welcome, Michelle.
Thanks so much, Dr. Biddison.
And also with us, Dr. Maura McGuire, Executive Director for the Office of Johns Hopkins Physicians Strategic Learning Center. She directs education and training in Johns Hopkins Community Physicians and works as a primary care internist. She also serves as Assistant Dean of Part-Time Faculty and as an Associate Professor of Medicine in the Johns Hopkins School of Medicine. Great to have you with us, Maura.
Thanks, Lee.
So I just want to plunge in to share with our audience some of the amazing things that you all have been doing to really improve our clinicians' experience interfacing with the EHR. I think people think of, well, in our case, Epic or whatever your EHR is, wherever you are. You hear the word Epic and it's a dirty word, and in many ways, people groan, roll their eyes, all those things. You guys have seen this for sure. But it is also an amazing tool, and you guys are doing such wonderful work to really help our clinicians move forward in that space. So maybe we could start off just with the basics. Can you tell us a little bit about the Strategic Learning Center? Maura, how about you kick us off?
All right. Well, we started the Strategic Learning Center about 3 years ago to sort of provide some operations-focused education to our ambulatory practices. And we'd been doing this for a while in our big ambulatory care group, that's Johns Hopkins Community Physicians. But we didn't have the same kind of operations-based training for some of our academic practices or health system practices. So we thought, wouldn't it be great if we could identify a team to work with teams where we're delivering patient care and kind of provide ongoing coaching around standard operating procedures for patient care in the practices, and just help our managers and our, physician staff have staff that were trained up to help them do the work they need to do. So that's it in a nutshell. We kind of focus on a couple big areas. One is just clinical support staff, and that would be medical assistants, nurses, MOCs, techs, all the people that make things work. So making sure that those folks have know what they should be doing, have standard operating procedures and follow them. And then working, through Michelle's team to improve Epic skills. So Epic efficiency is another big one, and I'll let Michelle talk about that. And then the other thing that we try to do besides staff education is just, billing and coding basics for professional billing, just to make sure that people put in a lot of hours, and we want to make sure that they know how to use the existing codes to just capture the value of all the work they do. So those are our big three things.
That's fantastic. Anything, Michelle, you want to add on that piece?
So it's been a really great to be able to bring this forward to our academic practices. And like Maura said, we've been doing it in Johns Hopkins Community Physicians for a long time. And so, you mentioned groaning when you mentioned EHR. And I think when you start talking about in-basket, which is where we really started from an Epic efficiency perspective, the groans get even louder, right? That's all the work you have to do after you finished working.
Yeah.
And, looking to see where we can standardize workflows so that it's easy and repeatable, and where we can engage the team in that work. And really the goal there was to lessen the burden on the providers. And that's been the focus. And then so our in-basket initiative has been called the Great Eight, which was a term coined by Dr. Steve Sisson. In this, we had a physician improvement work group that was really looking at how do we tackle this problem, and they came up with the eight sort of message types that we could focus on to kind of streamline and places where we could engage the team, because we have a lot of people, as Mara mentioned, there's a lot of clinical support staff. Sometimes it doesn't feel like there's enough, but there is clinical support staff. So we have CMAs, we have nurses, we have administrative staff supporting care of patients. And how can we really engage everyone in this work rather than just leaving it to the physician to figure out?
So say more about, I've heard lots about Grade 8 and wonderful feedback, but tell us a little bit more about what the Grade 8 program looks like. Do you want to go first, Michelle?
Sure. So we have tried to tackle this in phases. And, the interesting thing about InBasket is I think when we went live with Epic 10, 12 years ago, we didn't really know what that work meant. And I have to apologize to all of the clinicians out there, because I was the one standing up in front of the room saying, it's not any different than the phone calls you get today. It's just the same work coming in a different way. And I was so wrong about that. So you will self-screen out of waiting on hold on the phone, but not at 10 o'clock at night when you can just shoot off a message from an email message or a patient eye chart message, right? It's so easy to log in and send every thought that you might have, every concern as a patient that you might have. It's so easy to outreach, and that volume of work has exponentially increased, and our staffing has probably not kept up with it. So I was so wrong about that 10 years ago. I apologize to everyone who heard that from me. um, so and we never really thought about InBasket, right? Of like, what does that look like? How should you tackle that work? What should the standard operating procedure be? And as we've been meeting with clinics, there's not been sort of structured standard work development around this. Whereas we have a standard intake process, right? When you come in, where there's a standard check-in process, the MA rooms you and takes your vitals and goes through sort of a standard workflow. There's really no standard workflow around InBasket task management. So we started this work back in 2021 with just some really basic workflows, really building off a program that JHCP had done years ago. And, having that education and training team, they've been a little bit ahead of us. And so really building off of that with just some really easy standard workflows on how to process a prescription refill request, for example. So making sure we're using a standard smart phrase or a standard template, if you will, to tee up information for that physician on when was the last time that prescription was ordered? Does the patient have any refills left? Because if the patient has refills left, that doesn't need to go to the physician. I can just call the patient. When was their last visit? When is their next visit? So that you as the prescriber have all the information you need at your fingertips in order to say yes or no to that request. We did some really, really basic training. We do not have a great continuing education program around the EMR. So there were a lot of new features and functions within Epic that people didn't know about. So we spent time just presenting at faculty meetings, doing staff meetings, webinars to kind of do a catch-up training. Phase 2 of that program has been our InBasket Sprint, and that's the fun part. So that is a 3-month engagement with a division, a department, a clinic, where we do a really deep dive on what does your message routing look like today? Where are your messages going? Are they going to a pool? Who's in that pool? Is that going to someone else who can triage the message, or are the messages going direct to the physicians? And then in that case, can we reorganize that so that they're going to support staff first to be triaged? Because what we're finding is patients send all kinds of questions in MyChart, to like, I need an appointment. How do I get to your office? A lot of like, can I get a copy of my medical records? I need a copy of my referral. So things that physicians don't need to answer and probably aren't best suited to answer.
Makes
And
sense.
so
Yeah.
getting administrative staff to handle the things that they can. So we developed a scope of practice document, our ambulatory directors of nursing, got together across the enterprise so that it was consistent across the enterprise of who could do what in terms of responding to messages. And then in that in basket sprint, we develop message handling guidelines. So if you get this kind of message, this is what you do with it, and get very specific. And that's been really helpful to help the administrative support staff who may never have really been engaged with this work before, give them very clear instructions. And so once everybody agrees on what those guidelines are, we do one-on-one coaching with every provider, every staff person involved in basket work, so that we can review the guidelines and then make sure they have the EPIC tools that they need to be successful in managing those messages.
So do those guidelines vary by clinic or vary by department, or how does that work?
They can. There are a lot of very similar message scenarios across departments. But you might imagine, medicine department's going to have a lot more prescription refills than a surgical department. A surgical department's going to get a lot of questions about what happens, when is my surgery? What are my pre-op instructions? A lot of post-op, questions, wound care, things like that, that you're not going to see in a medicine. So there's some variability to, by and large, pretty similar kinds of questions. And then where it varies is if I get a scheduling question, am I sending that to a scheduling pool? Am I sending that to patient access? Am I sending that to the provider's MOC or a medical office coordinator, which is an administrative person, support person? So we definitely allow for that variability. A lot of it's going to depend on the staffing within that department. So some departments have a lot of nursing, and nursing is involved in that message, whether as the first triage person or in a nurse triage pool, where if it needs nursing support, it goes to nursing before the physician. Other departments don't have a lot of nursing in the clinic, and so it's more administrative staff. So the guidelines will vary based on scope of practice.
I can, that all sounds great. I can imagine folks getting nervous. They're like, well, do I have to do this just like my colleague in this other department that's totally different from me? Because I think there is a lot, and there's pretty good data to suggest that like standard workflows are helpful, but if we over standardize or over control things, that can actually make things worse. So it's great to hear that this wonderful balance of both standardization and flexibility is fantastic. So how many clinics have done this?
So we've gotten through 100% of the Johns Hopkins community physician clinics and about 20% of the School of Medicine clinics. And so size-wise, the School of Medicine is quite a bit larger in terms of number of locations.
So
Yeah, and that amounts to more than 120 different clinics or departments have done this training, which I think is it's really a huge number given the small size of our teams.
that is amazing. Well, tell us what you're hearing about people's experience with it, how it's going, once you've come and gone, how people are doing. Tell us more about the impact. Maura, you want to take that one?
Well, we do have a couple numbers that we've been trying to take a data oriented approach to just looking at our outcomes. So one of the things that we did when we started the program was that we developed a dashboard that looked at a couple of what we call our key performance indicators. So, there are a couple of things we've been trying to get people to do that we think are simple steps to improve their efficiency. And actually, let me go back to what are the Great Eight. Those are the things that the work group that Steve put together identified as tasks that they commonly manage through their in-basket where they thought they needed some help. So the Great Eight are test results, prescription refills, patient medical advice requests and phone calls from patients, appointment requests, referrals and orders, letters and form completion, supplies requests, and then finally we added learning to use Haiku, which, as you know, is our local app for Epic. And so for then what we did was we went through our in-basket messages themselves and identified the volume in those big buckets. And in fact, as the people on Steve's workforce had just imagined, the big pieces of the in-basket pie are test results, which is almost a third of almost everybody's in-basket. Prescription refills are big in primary care, less big in some specialties. Patient medical advice requests, though, are also very big. And then the other things like appointment requests, referral requests, letters, and supplies are things that staff really have a huge role in managing. So we kind of took a look at the pie and then we decided, can we find one thing that everybody can do as a team to improve the efficiency of managing that slice of the pie? We looked at, for example, in the results bucket, we've been trying to get people to think about using a quick action, which as every Epic user knows, is something that bundles a couple of clicks together into essentially a macro where it's a one-stop completion for what might be a complex task. So we're really trying to get providers and staff to identify a couple of common quick actions for their most common results that come into them, whatever their specialty is. Another one is prescription refills, again, very big in primary care. And, what we've learned is that frequently people don't prescribe patients the maximum number of refills, even for stable medicines. So, if you can imagine, if you have a patient on a stable medication, like maybe a statin for hyperlipidemia, the dose of that changes pretty infrequently. So why not just give that patient, the maximum, the 90 or 100-day supply, and then give them 3 or 4 refills? But it's interesting that that's not a universal workflow. And if we're having people call in after 6 months, or even in some cases 1 month for a refill, that can really increase unnecessary noise in our in-basket.
For sure.
So we're just advising, give them 3x4 refill response. And then for PMARs, those are complicated. So patient medical advice requests. So those are our MyChart messages. What we've noticed is that a lot of those include things that really require a physician or a prescriber to respond. But at least a third and sometimes up to a half of them in many audits that we've done are asking for appointment requests, which really don't require the prescriber to get involved at all. So some of them are doing simple things like, hey, I'm coming to see you. Can you put in lab orders? Well, staff can do that. I need help making an appointment for a test that you want me to have done. Staff can do that. I need help printing out my med list. Well, staff can help patients do that from MyChart. So what we've done a lot of work with, and Michelle has really led this, is helping each practice that engages with us go through a guidelines work group and develop, some standard management approaches for the patient medical advice requests that come into them in their specialties. And maybe I'll let Michelle talk a little bit more about that.
That'd be great. Michelle, tell us.
Sure. So we start with an audit, and so that's the best way we've found to really understand what's going on. And so we'll actually go into Epic and look at the messages that are coming into either that clinical support pool or that physician in basket directly, and grab the general scenario. So is this an appointment request? Is this I need a referral request, et cetera, and sort of categorize them and look at how the staff handled that message. And so in a lot of cases, because again, no one sat down and really thought through what this work should look like or the flow should look like, our clinical support staff was just a pass through. They're just forwarding the message that they get to the physician, and maybe reading them, maybe not, and again, because we didn't tell them what to do with it.
Right.
So when we will take, the message scenario, what happened, but what could have happened. And so we stole this, I think, from Vanderbilt at this term, mature the message.
I love that. Yeah.
So it's so good. And we have a whole video series on maturing the message, that sort of speaks to sort of why and what this can do. And it's really taking that message and how can you add value before you send it to the next person? How can you make it easy for that prescriber to answer that question? And so it might be calling the patient back to information. It might be, I don't need to send this to the provider at all because they're asking for their lab slips that went to Quest, and we did a system quick action. So with a one click, you can reply back to the patient with screenshot instructions of how they can go into MyChart and find that information and print it out for themselves. So that's really been eye-opening, I think, for a lot of groups to sort of understand, what my staff can do for me, how my clinical support staff can support me. And then it requires training, right? So you can't just like turn these guidelines over to your medical office coordinator and say, do this without, then we come behind and really show you how do you search the chart for the information that we're asking you to tee up for the provider. How do you invoke that smart phrase or that template? And we put that as a speed button at your fingertips so you don't have to remember what it is. And we kind of set people up for success that way. And then we continue to audit after the fact, once that training has happened, to see if those workflows are sticking. And then our phase 3 of our initiative is really sustainability. And so we have a small grant that we received from MCIC, which is our malpractice insurance carrier, to really help with the sustainability work. And we're embedding coaches in the practice. So after the sprint, we don't just disappear. Now, not for everybody because it's a small grant, but for those identified that we're piloting, and hopefully, this will build momentum and the program will grow, embedding that coach to continue to regularly audit, look for folks who might need some additional training. One of our audits identified a new nurse who had just joined the practice and hadn't really gotten a good orientation on those workflows. And so we were seeing a lot of errors in how she was handling the messages per the guidelines. And so that was a great signal to get in there and do that coaching and sort of get her on the right track right from the beginning.
That's fantastic. It's so exciting to see how these simple, sort of straightforward structures that we really need and often aren't able to do for ourselves, can make such a difference. So tell us a little bit about how the work has been received, what people are saying.
So I think one of the providers, it was really heartwarming to hear. He had been receiving all of his messages directly to himself. So one of the things we do at sort of the beginning of the sprint is an audit of where messages are routing, because sometimes the Epic build gets a little off track, or maybe you didn't realize there was another option. So we have quite a few providers who are receiving their own messages. And we were able to switch him so that the pool is receiving the messages. And then what's needs nursing input is going to his nurse, and it's getting triaged appropriately. And he said it has had such an impact on his quality of life.
Oh,
And so getting messages on Saturday night at dinner with his family that he feels he needs to respond to right away, because those messages are going to the pool, they're getting triaged, appropriate, going to his nurse, and he's getting them during work hours, which is really what MyChart, those messages were designed to be handled and responded to during work hours, not sort of, in those off hours in the family time. So that was really great to hear.
that's fantastic. That promoting work-life balance by working more efficiently is wonderful.
Well, I just want to add to that. One of the things that we've been trying to communicate is uh, what the provider work hours might be like, what prescriber work hours might be like to our staff, right? So, everybody works really hard during their their standard workday, but we've been trying to figure out how to engage people in this. And I think some of our very busy staff might, rightly say, well, why should I do more work? I'm already working really hard. So we've been trying to connect with people at an emotional level too, right? Just kind of sharing. The goal is always to take care of patient needs as quickly as possible, but staff may or may not know that the people that they support are going home, and then after they finish all their notes, right? One of the things you've been working on is pajama time.
Right.
So we know that the average, just say primary care provider puts in, 1.5 to 2 hours of after hours work for every 4 hours that they see patients. And a lot of that happens because of this in-basket work. So we've just been trying to communicate with staff in really simple ways that your providers don't stop at 5 o'clock like maybe you do. They go home and then they open up their computers for another 2 or 3 hours, maybe around midnight, and do a bunch of this work. And you can really, we really want to create that feeling that we're a team and we're all in this together. So letting staff give providers feedback, if providers could do a better job of supporting the staff, is there
Oh,
something the staff would like us to share? But also giving providers the chance to coach their staff and really get them involved in making it be uh, a, a team communication process, so we can get the work done but support each other, and I'll show up at work the next day rested and happy and ready to do another day of of care.
makes such a difference. And I think, it's builds cohesion, right? When we understand what our role is within the team and not, the sometimes I think the just the pass through piece, it lacks meaning. But when, as a staff member, if I can engage in a way that's meaningful, both to the patient and to the rest of the team, that's helpful. That I think can be really impactful. That's really fantastic.
Yeah.
Agree.
And some people are really struggling, right? So one of the other things that Michelle's done is uh some of the training team have worked individually at the elbow with providers who had huge in baskets with lots of folders and lots of old messages and things that they just couldn't emotionally get around cleaning up. And just the work of sitting down with someone and making suggestions, consolidating folders, getting rid of old messages, that were already addressed, but just kind of sitting there. And then letting someone come into work the next day with a small, succinct in basket that they can
Yes.
actually maintain going forward. So, those are some of the things that we're also trying to do with this project. And it's a culture change. It's just saying that over the last couple of years, as we've started using um, Epic, we haven't always done it as well as we could. So learning to do things better, and changing the culture from people don't like it to, boy, this is a great tool. It can help us work together, get work done in a way that really supports the well-being of everybody, including the patients, including the staff, is something that we've tried to get to.
It's fantastic. I love that community building. It's wonderful. Michelle, it sounded like you had something to add.
Oh, I was just gonna say, I so agree with you. I think having the staff have meaningful impact to patient care helps them feel part of the team and feel more engaged. And we want those folks to be, engaged and happy working here because we need them to support our clinics.
Absolutely. Well, so it sounds like there are a bunch more clinics in the School of Medicine who still need this. Are there other things on the horizon for the Strategic Learning Center in this space or related spaces?
Yeah, I think our sort of motto for FY25 is moving beyond the in basket and really tackling some other areas of Epic efficiency. And we are partnering with the clinical education team that's led by Julie Petter, who does all of the Epic education to really enhance onboarding. And what happens after your initial Epic training when you initially get access? And how do we create more options for continuing education and the cadence for learning so that we're not just sort of giving you, 4 or 8 hours of Epic training and then setting you loose and really helping people understand Epic is incredibly powerful, and I think it can be a really incredible tool to help you care for patients. But if you can't find the information and you can't navigate the chart, it's a burden, right? And so we
Right.
want to have people enjoy it as the tool that it is. But you need more probably than that initial onboarding training.
Yeah, that totally makes
And I,
sense.
and I think also, as we implement other tools that are supposed to help us increase our efficiency, just being thoughtful about where people might need help to, do the quick implementation thing and then take advantage of them. So, we recently went through, so we just want to be thoughtful and provide more at elbow coaching in the places where people need it. And that's something that we're not necessarily well staffed for, but our strategic learning center could help. So think about the e-consent form that we implemented in the last year.
Sure.
I know a lot of colleagues knew it was easy, but they just couldn't quite get that first e-consent signed, and they really struggled with it. So just imagine putting, a coach in the major OR areas, just so someone could come and say, "I haven't done this before, just walk me through it." And, one and done. And, I know you talked about our new AI scribe that's coming live in one of our podcasts. Another thing that I've heard is really easy, but I can imagine that I and maybe some of my colleagues who are a little more tech challenged, might need someone to just sit down there and say, "Let's do your first note. Let's get you set up," just so I don't have to look at
Yeah,
the ticket
absolutely.
when I'm seeing patients. So, I'm just thinking there are other areas where we can be thoughtful as an organization and say we're investing in expensive technology to help us be more efficient, but where will a hand help? And is that something that a group like the Strategic Learning Center should be able to assist with?
That's fantastic. We, have the technology. We've made the investment in the technology. Now let's get you to where you need to be to really
Right.
utilize that. I think they new technologies can feel a little bit like that black box, and I'm not really sure. And how do I get started? And for the for the early adopters, it's perhaps an easy thing to just plunge in, but for the rest of us, it can be a little intimidating. So I'm so grateful you guys are there. Well,
It's just
specifically around grade 8, can I ask just quickly if somebody's listening and is like, "We need this ex post haste in our clinic." How do they reach out?
Absolutely. So we have an in basket. We have a email address, inbasketqueries@jh.edu. So feel free to drop a line. Feel free to reach out to I would say myself and Maura directly, but maybe I shouldn't offer that. But in basket queries at h.edu, will our amazing project manager, Carrie Burlett, manages that inbox, and she will reach out and get you set up.
Fantastic. So just one more time, in basket queries
At
at jh.edu. Okay, great. And we'll put that in the notes for the podcast as well so people will have it. Well, Maura, Michelle, thank you so much for this incredible work, for all that you're doing to support all of our teams and, in turn, all of our patients. It makes such a difference, and we are super grateful. Is there anything, as we wrap up, anything that I didn't ask that I should have before we go?
I would just love to say to all of the physicians out there, when we are take advantage of coaching. I know it feels burdensome to set aside 30 or 60 minutes to sit down with someone, but it can really save you so much time. It's a small investment to save you a huge amount of time after the fact. And I've sat down with so many physicians who will say, "I don't know why I'm here. I've been using Epic for 10 years. I was told I had to be here and meet with you." And then within 5 minutes, they're like, "Well, I didn't know that. Well, why didn't I know that? Well, this is amazing." Trust me, it's worth the time to spend.
It's great advice. Maura, any last words?
No, I think Michelle's covered it all.
Well, thank you both again. And for our audience, this has been the Vital Conversations podcast. And I'm your host, Lee Biddison. Take care and be well.
So that's it for today. If you enjoyed what you heard, please share this podcast with a colleague. And as always, we welcome your feedback.
If there are any topics you'd like to hear about, please email us at owb@jhmi.edu.